Good morning, everyone, and thank you so much for coming to our panel discussion. We're going to be talking about Ozempic and all of the GLP-1s. My name is Dr. Pamela Cipriana. On the end, we have Dr. Srivani, Dr. Ron Lal, and Stefan Wall. I am going to make a disclaimer because my mouth is like a gumball machine, so sometimes things will come out of it, and I don't mean to offend anyone. Just very passionate about what I talk about, so there's my disclaimer. I'm the founder and president of the Practice of Health and Wellness, and I'm the CEO of IV Hydration Lounge and Med Spa. We're going to be discussing how each of us uses these GLP-1s individually and how we see them fit for our practice. So I'm going to start that I have a clinic. It started off as an IV hydration lounge, most for health and wellness. And when semaglutide came out, and we weren't able to get it approved for by insurance companies for weight loss, we started using compounding pharmacies for this. And my experience, I think, is different than other people will see it, just because I've had a lot of experience, mostly for people who want to lose maybe 50 pounds, even 100 pounds. In my practice, the way I use it is we start at a low dose and we slowly increase. If you're losing weight on the lower dose, we don't increase the dose. And the goal is to lose between 1 and 2 pounds a week. Along with the compounded medication, I also counsel patients extensively. They all get a diet that was designed when I earned my doctoral degree. So it's all foods that are low in glycemic index and decrease inflammation in the body. And even without any of the GLP-1s, you're going to lose weight on this diet, provided you follow it. So as soon as you start adding back the junk foods, you're going to go back to your old ways of eating, and the weight's going to come back. So for me, being in the ear of people every single week, weighing them in, how are you doing with your diet? How much water are you drinking? Are you having any complications with constipation? That's the most common side effect I see. Very, very few people I see with any nausea. But again, I'm dosing it very, very slowly. So that's my take on it for weight loss. I'd like to have everyone introduce themselves and how they use this medication in general. So, Dr. Srivani, I know that I would like you to talk about, first introduce yourself, and then talk to us about how you see it as a pharmacist.
Hello, everyone. Great topic to talk, right? Most popular topic. I hope you had your great breakfast and sugars are spiking up. So let's see how they are working inside your body right now. And March 4th happens to be the World Obesity Day. So it's a honor and pleasure to talk about it, educate my audience. I have been a pharmacist, medication therapy management provider, birth control prescriber. I'm a chief medical officer for COVID vaccination clinics, and I practice in heart of Silicon Valley, Sunnyvale, California. And my pharmacy is modeled around Qubit Wellness Pharmacy. Preventative care is my goal, educating my patients, my doctors, bridging the gap between the patients, doctors, insurance, advocating doctors' concerns, patients' concerns to the doctors, and doctors' diagnosis and therapeutic goal to the patients is my key. We have 300 Google positive reviews, and it's a testament of our dedication and commitment. And I'm very happy I collaborate with a lot of endocrinology and weight management clinics, and we had great success in our clinic managing the patients with, I can count on my fingers. Out of 1,200 prescriptions we sell, we have very few, very rare side effects we have noticed. And this molecule, as a pharmacist, is not new to me. I know this molecule, this family, GLP-1 agonist, since 2005. Exenatide was the first molecule released by Amylin Pharmaceutical Company along with Eli Lilly. And they tweaked it a little bit because at that time, the molecule was injected twice a day. And then they tweaked it to get it to once a week under the name Exenatide Extended Release. 2005, 2008, 2012, when the extended release was released. And I know that molecule has helped a lot of patients. All the little bit side effects were noticed, but nothing was scientifically proven. Nothing was linked. There was only warning, so FDA kept on, increasing the side effect warning, adverse event warning. Side effects are different, adverse events are different. So they gave black box warning, they gave tools how to manage that. And pancreatitis or thyroid carcinoma noticed in rodents, there was adverse events, but nothing was proven to be scientifically correct. What I noticed when prescribed correctly, when the therapeutic goal is not just weight loss, if they're prescribed correctly, under supervision of healthcare provider, patients have done amazingly well. Very minimal side effects, because patients don't know. They just think it's a weight loss miracle, but they don't know it's tweaking with their pancreas. It's tweaking with their brain signals. So as a pharmacist, I take extreme pride in educating my patients at molecular level. And once it got approved for weight loss, and I just want to let you know, I'm not selling any drug here. I'm talking about at preventative care level. So either semaglutide approved for obesity, and that it got tweaked to approved for weight loss under a different name. And the other molecule, tirzepatide, it's a dual receptor, and it got approved for both diabetes management and weight loss. They are good molecules if they are done right. If you're done right, they're giving good results. So I have seen great stories. My patients always come back and share great, progress in their health and how we help them manage that. So I had great reports about that. Thank you.
Thank you so much. Dr. Lal, if you would be so kind to tell us how you feel Ozempic can be used in surgery.
Yeah. Thank you. I appreciate it, Pamela. Good morning, everyone. So I'm Rohan Lal. I'm a neurosurgeon based in Minneapolis, Minnesota. I'm a director of neurosurgery at a large health system there called mHealth Fairview. In addition to that, I'm chief medical officer of a new medical device startup company called Synerfuse that has developed a novel surgical procedure called the electrified TLIF, or eTLIF, where we're incorporating conventional spinal fusion with direct nerve root stimulation to kind of improve pain outcomes. So, none of that really has anything to do with Ozempic, frankly. But what's interesting about it is it's so pervasive in medicine these days that if you are a doctor, you are around this medication all the time. Even as a neurosurgeon, a tremendous percentage, God, who knows, certainly maybe a third of my patients may be already on this medication. And I think some of that has to do with the general obesity levels, diabetes levels, and health of the American populace. But specifically, I think to that question, one place that I see it all the time is that in spine surgery in particular, there's such a correlation, one, between weight and the degeneration of the spine. So, the more obese patients have more degenerated spines, they have more debilitating pain as a result, then they become disabled, then they're not able to basically pursue the activity levels, and they end up gaining more weight. So it becomes a real sort of chicken and the egg problem that sort of compounds on itself. I was at the Spine Summit, the Congress of Neurosurgeons Spine Summit 2 weeks ago, and Dr. Glassman from Louisville made a great point that he said that, we've had some technological advances in spine surgery. Certainly we're excited about our new direction. But in many ways, a lot of the improvement in outcomes in surgery these days has come from just the medical community learning how to better pick surgical candidates. And so one of the most important, there's some basic things. 15 years ago, they were still doing, spinal fusions on smoking patients, right? We realized that, that's an absolute non-starter. The fusion rates, drop from 98% to like 60%. So these days, for example, insurance nicotine tests everyone before they can have a spine surgery or a spine fusion. But similarly, one of the biggest determining factors of outcomes in spine surgery is body mass index. And what we have learned is that patients with a BMI greater than 38 universally do substantially worse in terms of their functional outcomes, pain outcomes, and complication rates after surgery, to the point to which many of my partners refuse to even see patients these days with a BMI greater than 40. I am philosophically a little bit more sympathetic, and so a lot of times I will see patients, at a BMI of 45, 47, 50, even if I don't think they're immediately a surgical candidate, just to kind of review their issues and what's happening with them. But one of the very critical roles of the GLP-1s, GIPs, all these medications these days is if someone comes to me and they've got an unstable spine, they've got disabling chronic pain, and they're at a BMI of 45. The question is, how can we use these medications to get them into a BMI range where they can potentially become a surgical candidate, have a better outcome with surgery, potentially avoid a complication? And so that is something where, 10 years ago, our main weapon for that was potentially gastric bypass, which is obviously a much more aggressive and risky surgery with higher complication rates. And these days, with being able to get patients onto a GLP-1, it's a much safer way to get them down 10 points on their BMI and potentially get them to a position where we can fix their back and try to get their life back on track.
Thank you so much for that. Stefan, if you would be so kind as to talk to us about what you're seeing in Germany when it comes to insurance coverage and how it's used for diabetes.
Yes. Thank you. Good morning, everyone. My name is Stefan Wahl. I'm a pharmacist from Germany, and I wanted to share the experience from Germany with the medication. In our company in Germany, we are providing a follow care up for or after bariatric surgeries, and we have a care program for type 2 diabetes patients. And in Germany, the medication, the GLP-1 agonists are more used by the type 1 diabetes because the insurance companies pay for these medications and they don't pay for the medication against obesity. In Germany, the type 2 diabetes is a disease, and the obesity is only a risk factor. That's not my opinion, but that's the regulation we have. I heard in the US they paid also for obesity, but we have in Germany not such a big problem with obesity. We have in Germany a big problem with type 2 diabetes, and there the GLP-1 agonists are very important for us because the type 2 diabetes has very only a few medications. Sorry, medicament is a German word. Only a few medications who can get, and then you get insulin, and insulin has the problem to increase the weight, and you need for these patients normally medication who decrease the weight.
Thank you so much. So I think part of it too is we have to talk about diet, and especially in the United States. I can't speak for Germany, but the United States, when I was in nursing school more than 30 years ago, the 50% of the population was overweight. 30 years later, 50% of the population in the United States is obese, and it is directly related to the food that is supplied to us in the United States. Everything in this country is for profit only, and there's no concern about our health and our disparities because of the food that we're eating. So if you eat something simple as beef, pork, or chicken from a grocery store that's not in the organic section, you're getting a host of issues with your metabolism. I know everyone talks about organic fruits and vegetables, which is definitely important, but organic meat alone, I have seen people lose weight and reverse their risk factors. In my med spa and in my medical practice, as soon as I change something as simple as having people buy wild-caught fish and organic products, their weight starts to come down automatically because you're decreasing the inflammation in the body. So I think that's something else that we should be discussing is, educating people on not only risk factors, but also what types of food to eat. You know, my diet is exceptionally clean. This morning I had fruit, I had some of the eggs, I did have a piece of the little chocolate muffin. So I'm able to take a piece of the muffin to see what it tastes like. In my office, we have dozens of donuts in that office every single day from drug reps and patients. And I know me. I will not taste that donut because I know I'll eat the whole thing. And then I'm going to feel absolutely miserable. My bones are going to start cracking. I'm going to be inflamed. So it's just not worth for me to even taste it. So I think you have to know what you're capable of on your own. So I'd like to open it up for everyone to give an opinion of how they see Ozempic or semaglutide or tirzepatide or any of the GLP-1s, and how long a patient should stay on it, and how we go about getting them off of the medication eventually. Because right now in the package insert, it is recommended that the patient stays on this medication indefinitely. If you change their diet, there's no reason to stay on a medication indefinitely. Almost any medication can be discontinued, aside from a handful of medications that should never be discontinued. So let's start with Dr. Shivani.
Yes, absolutely. In my experience, I love semaglutide molecule for diabetes management, surely. And I want to remove this stigma also, like, oh, this guy is binge eating, he can't stop eating. But when I went for the training classes and sessions, when these GLP-1s are getting popular and I have to take extra, education, what I learned, just like you're deficient in, some people can be deficient in thyroid hormone as you age or due to trauma, stress, people can be deficient in GLP-1 agonist molecule, in the hormone in your system. This hormone is present from the tip of your tongue to the intestine. It tells you to stop when you're full. It tells you to even pick right food. So when they're deficient, it's not that they have a bad lifestyle, it's just they're deficient in that molecule. That hormone is not there for them. So they just don't know when to stop. They just don't know what to pick. It's just the brain signal itself is missing there. So I had great stories. One of my customers tells me, Srivani, before I got this tirzepatide, I would go straight from work to KFC, pick up a bucket of chicken wings. But now, after 5 months of using it, like we tapered him up very slowly up. We got him, not necessarily everyone has to be at the highest dose. There is always, I always go by the therapeutic goal, not what needs to be, followed by the prescribing guidelines. So he got to a medium dose and he says, now I go home straight. Even if I open my fridge, I want to eat healthy. And he also became a part of 5 a.m. club, like going to gym at 5 a.m. And he was also having cholesterol issues, knee issues. Like this is 1.5 year of journey he shares with me. And he still uses it for cravings, not like once a week as should be according to the prescribing guidelines. So that is a great, achievement. So I always tell the patients too, this is approved by the FDA along with diet and exercise. Not purely this molecule should be your miracle drug. Don't explain to me that you're a software engineer sitting at the desk coding all day, you need this molecule because you're gaining weight. Before I get your authorization, I need to see you're committed to 3 weeks of, 3 days of workout, a good diet log. If still that doesn't work, then I'm here for you. I will have the molecule work for you. And not only that, we counsel them on what to monitor for side effects, because the key to success to this journey is please do not eat too late in the evening. Have your dinner 3 hours before bedtime. Avoid heavy meal at bedtime. Make sure you're upright at least for 30 minutes before bedtime, after your dinner. And then eat healthy food, gut diet. The gut health is brain health, and for women it's vaginal health too. And so make sure you're eating a good diet that includes what this GLP-1 is doing is trying to get hold of your excess carbs that turn into sugar. Right? So you need to cheat that GLP-1, not get your food. So what you can do is get your protein, get your fiber, get your probiotics, because fiber helps your gut hormones responses better. Protein helps not lose your muscle mass. GLP-1 will not target your protein, it will only target your carbs. So having these principles, eating early evening, light meal, avoid fatty foods, get healthy fats in your diet, that has given a lot of successful stories. So it's a comprehensive complementary care that can get them to successful stories. Just like any other prescription, follow the guidelines, consult a certified healthcare provider. Any questions, contact us. Thank you.
Thank you so much. Dr. Lal, how do you see the GLP-1s being used in surgery? What would be your cutoff for a BMI to actually do the surgery and maybe talk to patients to stay on the medication for a certain amount of time before they actually stop it? Like, what would your recommendations be?
Maybe before that, though, yeah, I think you both raised a couple of really good points. Okay, first of all, health and weight are not synonymous, right? So there's a lot more that goes into being healthy than just having a BMI less than a certain number. And so my wife is a internal medicine physician, but very different practice than yours. She's in a bit of an underserved community, very large patient panel, 10, 15-minute appointments, 25 patients a day. And so one thing that she's always mentioned to me is that one of her challenges with these medications is that in terms of likelihood of patients getting what they want out of it or success, so much of it goes into the other side. Are they able to make the diet modifications? Are they able to exercise? If you aren't able to bring that part of it to the table, you may not get what you're looking for out of this medication. So I think that, it is so crucial what you were both describing, that you must make the lifestyle modifications, kind of in addition to the medication to really get the goal. I think additionally, we've sort of all kind of looked at this in a different way, but broadly speaking, I think an important consideration with these medications is what is a patient's individual goal here, right? Is it aesthetic? Is it just trying to lose that 15 pounds? Is it treatment of diabetes? Is it trying to become a candidate for a surgery? And I think that those individual goals really tailor, in many ways, probably the ideal dosing strategies, what the end game is, and whatnot. So to answer the question of surgery, I personally have different BMI cutoffs based on risk profiles of surgery. So sort of, the higher the risk profile of surgery, the longer the time under anesthesia, the more the blood loss. I'm going to be much more stringent in terms of trying to get those patients to an ideal body mass goal. A lot of my surgery these days is robotic and minimally invasive. Sometimes in those surgeries, if I know that, it's going to be, 35 minutes of anesthesia time, and the patient, has purely just like a small ruptured disc, I may sort of bend my rules a little bit. Ideally, I'd love to have them at a BMI of under 42 for that type of surgery. If someone comes in at 46, and they're basically, having a foot drop due to a herniation of a disc, I'm not necessarily going to, put them on Mounjaro for 4 months to try to get them to surgery. A lot of times I'll counsel them and I will say, I think your rate of a recurrent herniation or a hematoma or an infection is higher. We know that even obesity leads to higher rates of surgical infection. But for a big surgery, if we're going to go in and do a big scoliosis correction or something like that, where it's a long-term chronic disability, that's something where we're going to have to really take our time. Potentially it's worth taking 6 months, getting you on Mounjaro or something, and seeing if we can get you down to a BMI of 35.
Thank you for that wonderful opinion. I agree 100%. Now, how about in Germany? Because you really don't. Do you have a lot of obese people in Germany, like we do in the United States?
Obese?
Yeah.
No, we have obese people in Germany, but not so much like in the United States. In Europe, the obesity is not so big like here in the United States. So the medication is normally for the type 2 diabetes. And in the last years, we heard it here, there come much people who want only lose 5 pounds, 10 pounds, and they heard about it, and I come to the pharmacy and told us, hey, we want the Ozempic, we want the Trulicity, we want the Wegovy. And the problem was in Germany, we have a big shortage. The people wait until 5 or 6 months for his medication against diabetes, and that was a big problem. Yeah, they had blood sugar with 300, 400, and so the doctors couldn't make a prescription without told us this is a type 2 diabetes patient. Obesity, I think the problem comes in next years, and we have Wegovy only for obesity, and the other GLP-1 agonists or Mounjaro, we have with that GLP-1 and GLP also only for type 2 diabetes. Yeah.
Thank you so much. So I think it's important to mention too that GLP-1 is a hormone in everyone's body, and you can naturally increase your GLP-1 by eating a healthy diet. So when we're prescribing any of the GLP-1s, and we're including a proper diet that's high in fiber, low in simple carbohydrates, a sustainable diet where somebody can actually survive on this diet indefinitely, and it's literally pretty much everything that I eat. I think it's a lot easier to get people off of the semaglutide, because if they're changing their diet, they're not only learning how to eat properly, but at the same time, they're naturally increasing their GLP-1. And from the research I've done, unlike other medications, taking a GLP-1 does not decrease your body's ability to make the hormone. So it's not like taking something like Synthroid, which is going to decrease your body's ability to actually create the hormone for your thyroids. GLP-1 is in pretty much every cell in our body and in our brain, and that is our satiety level a lot of times, letting us know when to stop eating. When that number is low, and it's usually people eating a high diet in simple carbohydrates, the GLP-1 is going to be low. So I think for me, getting a patient off of the GLP-1, I will it depends on what they'd like to do. Some people will stop on their own, completely stop, and they really don't return to the med spa. I've had patients return, they might have gained maybe, between 3 and 5 pounds, but nothing ever really more than that, unless they're literally addicted to food. So even if they change their diet and then they come off of the GLP-1 and they don't have me in their ear every single week, how did you do with your diet? How much water are you drinking? Did you exercise at all? Any constipation? I've only had a few patients who've had to return to the med spa and go back on the medication. So that's what I've seen in my med spa. But I think that the nutritional part of it is the most important part before you prescribe this medication. And going even further than that, I have had patients who've come to my med spa because they were prescribed it by their primary care doctor who didn't do, and in their defense, you cannot see 25 to 30 patients a day and have time to counsel them on diet and exercise. It just doesn't happen. My practice is a concierge practice. So I have the opportunity to spend an hour with each patient. If it's a very complicated patient, I can have up to 3 hours with each patient. So my practice is different than what it used to be when I was taking insurance. Unfortunately, even then, I couldn't let a patient leave my practice without getting all of the knowledge that they needed. So I had patients waiting for 2 hours to see me, and I used to go home and tell my husband, I wouldn't wait 2 hours to see me. I was kind of surprised they would actually wait that long, but they did. So that's my take on how to get a person off of any of the GLP-1s. If it's for diabetes, I have reverse diabetes with diet alone, diet and exercise, without using any of the GLP-1s, getting patients off all of their medications. So, for me, I find that it's really what you put in your mouth is going to either make you really, really healthy or really, really sick. There's not so much in between usually.
I thought it was great you'd mentioned earlier when we were chatting, that for a lot of the patients where, it's maybe a more aesthetic concern, that your goal is to get them off in a fairly short window of time. And do you feel like it's really the lifestyle modifications that allow them to stay off of it?
That's been a huge thing, because the lifestyle modification. So when I did my doctoral degree, my dissertation was on preventing the progression from prediabetes to diabetes. So when I was 15 years old, my dad was diagnosed with diabetes, and every 15-year-old knows absolutely everything. And I'm trying to explain to my father at that age that if he just changed his diet, he could reverse it. And he saw that as a loving daughter trying to give him some silly advice. He did talk to his physician about it, and at the time, the this was not known that you can change your diet and reverse diabetes. It was more thought to be a genetic predisposition and a problem with your metabolism. So having my dad diabetic, my grandmother diabetic, and my 6 aunts diabetic, in my head, if I kept a very healthy diet, I wouldn't become diabetic. And so I've lived that way my entire life. When I did my doctoral dissertation, it was while I was working in my first primary care office. I had taken over the practice from an elderly physician who retired, and 80% of the patients were either pre-diabetic or diabetic. And it was just changing their diet that reversed the diabetes and reversed their risk factors for diabetes, just from diet. And the amount of exercising they were doing, they were getting off the couch, but they might have been going for a leisurely walk, just anything to get moving, because the more you move, those chambers on each of your cells start to open and allow the insulin levels to go in and then pull the glucose into the cell where it's supposed to be. So, whenever you're reaching for that piece of apple pie or that extra piece of candy, just remember what it's doing to your body and how it really is decreasing those GLP-1 levels, and it's going to increase your risk of obesity, and it's going to increase your risk of overeating.
One of the, maybe not criticisms, but things that I hear a lot about this is just, potentially maybe we don't have the longest term data and information. I guess I'm curious about both of you guys from a pharmacy background. What do you think you're beginning to see as we have maybe, where are we at, 10-year at this point? I mean, I don't know that there is 20-year data.
For GLP-1 agonists from exenatide, we do have a lot of data. It started in 2005. Now we're in 2025. So they have a lot of studies on GLP-1 agonists from exenatide molecules, impact, side effects, and adverse events. There were lawsuits on amylin, AstraZeneca, and Eli Lilly for exenatide molecule, but FDA has not shown any proof of that molecule has caused the adverse events. Side effects are very normal with any molecule. You can get overdosed on regular over-the-counter Tylenol too. So yes, there are side effects, and adverse events need to be carefully monitored, reported. We do manage, we do police where, the patient, for example, I had one young patient, as Dr. Pamela said, she wanted to get into her wedding gown. And we got her the new molecule, the tirzepatide. The beauty of tirzepatide is a dual receptor. It not only helps slowing down the gut absorption, controlling the cause, but it also mimics the brain to stop when they're full, right, and pick the good food. So she got that, and she got into her wedding gown. She also had other, metabolic conditions we call metabolic syndrome, right? She was not able to process the food she should, and she's gaining weight. So it helped. But then, 6 months back, I got a call from the doctor saying that she was pregnant, 4 months pregnant, and she was still taking semaglutide compounding molecule, and it's a contraindicated. Where did she get this? How? It was not in my pharmacy. So she asked me, what are the impacts on the child, on the pregnant lady taking this? I said, we only have rodent studies. FDA warned us based on rodent studies. So at this point of time, we just have to wait and see how it's going to go. So it's very important prescribers prescribe, healthcare providers, do the legit prescribing guidelines. Not always the therapeutic goal is weight loss or a better BMI. There's no perfection. I always tell my eye doctor, don't give me 100% correction to my eye lens. I don't need to see Leonardo DiCaprio that far. He'll come to me. So the same way in therapeutic goals too. What are the therapeutic goals? For some PCOS, young woman who wants to get pregnant, but they have PCOS. These insurances want them to use phentermine because it's cheaper, $5 drug. But phentermine is contraindicated in young women. Or what is the therapeutic goal for a, familial history with genetic condition of having hypercholesterolemia? That should be the therapeutic goal. Not always a BMI, I think, should be considered as, point. Like all my patients I have used for past 2.5 years, they still have a BMI, but they have a good lean mass. They have high BMI, but their cholesterol is clear. Some of them, they've got better, they got down with cholesterol medications. Insulin units have gone down. No more poking of so many times. So I see risk versus benefits. It is doing amazing job. Thank you. Thank you for the question. Thank you.
That's my opinion also. I think all medications have side effects. There are no medication without side effect. In Germany, our Secretary of Health told us at the beginning of COVID, the vaccination is without any side effect, and that was a lie, as we can see now. And I think it's a problem for the long-term data. We have the side effect like nausea, that's not a big problem, but we have the side effect with the vision. Rare side effect, but it is there, and we don't know if we had side effects like cancer. If we have data for 30, 40, 50 years, then we knew it, but not in the moment. And I think it's a benefit-risk ratio, relation, benefit-risk relation, and for the type 2 diabetes patients, there is a chance to die in a heart attack or blood, you have a high blood pressure, anything, and I think the benefit-risk relation is there very good. And obesity as a disease, I think this is also with a high risk for that. And obesity only for aesthetic, then I think you need more data, or you couldn't take the medication now. And the problem is also you need to change the lifestyle. In the last study I read that Ozempic by itself changed the food which the people eat. Yeah, less sugar, less processed feed. Is it the right word? Processed feed. Yeah. Okay. And so you need to have a healthy gut. So it's a big problem also in Germany. We don't have healthy guts. We don't eat probiotica. We don't eat fermented products. Okay. And so you must take a benefit-risk relation for every people.
I'd like to also add, I believe food is the same way. You're going to have side effects to whatever you put in your mouth. It's going to be either a good side effect or it's going to be a bad side effect. So it's not only the medications. You know, the Ozempic or tirzepatide might be the lesser of two evils, because you might be taking a molecule, but you're also decreasing your risk of so many risk factors by decreasing your weight and reversing your diabetes. So I see it that way as well.
Yeah, and I think it's just, this speaks to a bigger picture, you know, things that are exciting about where we are with it, but also, you know, some causes for concern, which is just that we're very new with all of this, right? And so, you know, from a brain perspective, right, there's a number of, you know, first off, it's interesting that, you know, we see levels of, you know, tirzepatide or even semaglutide, which are able to access the brain, even though it's not entirely clear that they cleanly cross the blood-brain barrier. So, you know, what kind of extracellular pathways are allowing them to even get into the brain? But we certainly know that we see these GLP-1 receptors in various different parts of the brain, in the hippocampus, basal ganglia, and really throughout the cortex. You know, I mean, there's questions of, you know, is there a role for this even in dementia going forward, or Parkinson's, you know, different medications, but, different conditions, but it's all so new. I mean, none of it, I mean, you know, some of this, there may or may not even be good mice data, you know, and certainly not human data to this point. But these are also exciting potential avenues and directions, I think, in the future, where if we're able to show efficacy, I mean, we may be just scratching the surface of different applications of these medications.
Absolutely. I mean, the data has shown, as I said, for my diabetes patients too, they were on 400 units of insulin, right? And after using GLP-1s, some of them got weaned off from insulin, no more poking so many times. So, and some of them are off of their cholesterol medications. Before that, we would just keep on increasing cholesterol doses, and the adverse events from statins, the, you know, myalgia that comes from them, the tiredness that comes from them, the cirrhosis that comes from them. But nowadays, we're not doing that after this GLP-1s. The statins, it has proven to have cardiovascular benefits. It is showing benefits in Alzheimer's. It is showing benefits in liver cirrhosis. And above show all the benefit of curbing alcohol binging. So it is helping with addiction factor too. So I am very positive when done right, this molecule can help risk versus benefits. And yes, it is still learning phase. It is still, we are still learning as it goes, but with the right way of prescribing, right education to the patient, giving them the right tools to empower their healthcare, we have good benefits seeing so far with GLP-1 agonists. Yes.
So just to extend on that as well, I know they've been doing some research on alcoholism and low doses of GLP-1 injections. And they're finding it to be statistically significant. It's still in the baby stages right now, but anecdotally, when I have a patient who would generally have, a couple of glasses of wine after dinner every single night, and they've been on the semaglutide for a while, they're no longer drinking at night. They just don't desire it. I have one patient who said that she would pour herself a drink, and she never even drank it because when she went to reach for it, she just didn't desire it any longer. So I think that that's a potential for it as well, where, like you had said, with the GLP-1s in the brain, where it's going to be able to change some habits as well, maybe decrease risk factors for things like Alzheimer's disease, depression, and possibly anxiety.
Also, Dr. Pamela, how are you handling the insurance issues? I know we discussed in the chat, you had big concerns.
So for diabetes, it's gotten a little bit easier to get that approved. I know in the beginning, which is so silly what I'm going to say, I would have a patient who had a BMI of 50, and I would get it approved for diabetes, and they may have lost maybe 20, 30 pounds, where they really needed to lose a lot more than that. But their A1C went from 8.5 down to 5.4, and the insurance companies would no longer cover the medication because they were no longer diabetic. I can't. I could feel a gumball coming right out of my mouth pretty soon. Anyways, what I have to do then is, you're always trying to figure out, well, how do I get this patient to stay on this medication so that they can reverse the weight, change their habits for a longer period of time before they do end up diabetic again. And that's when I found out about the compounding pharmacies, which made it so much easier for me to get patients to stay on track, because we're not bowing down to the insurance companies. We're not allowing them to be the doctor. We're taking medicine into our own hands, and we're allowing ourselves to work for our patients rather than working for the insurance companies. And I think that's a big part. When you can partner with your patient and they can see that you have a different avenue of how you can help them when their insurance company that they're paying thousands of dollars to every year is refusing to pay for something that I find to be a necessary drug and the patient finds to be a necessary drug. I think that they find that they have a provider that they can count on to be by their side all the time.
That's great, thank you. And also I just want to let audience know, we don't take everyone who needs a prescription, we don't dispense. Like I have a bipolar patient who couldn't handle any molecule. She takes high doses of lithium and other psychiatric medications. So she reacted very badly, especially nausea and diarrhea as well, with both semaglutide, injectable, and the tirzepatide. We tried every other week dosing too, instead of once a week dosing, but she couldn't because must be an interaction. Unfortunately, psychiatric medications do cause weight gain, but in this case, she couldn't handle it. We even tried the oral formulation of semaglutide because we thought once a week is accumulating in the body, so maybe once a day would be better for her, but she was not the right candidate. So maybe in that case, bariatric surgery, which still has 20 to 25%. But I have another psychiatric patient, depressant patient. He gained lots of weight due to antidepressants, and he's doing very good. So not necessarily every shoe fits everyone, right? In science, it doesn't work that way. So not everyone who wants to didn't get benefited, and we had to find other options and help them. Yeah, thank you.
I think that's a great point, because there is no 100% of one thing for anyone, no matter what it is. Are there any questions from the audience about any of these things that we've been discussing about the GLP-1s? Yes. Can you go to the microphone just so everybody could hear you? Thank you.
Okay, so anyone can answer this that you wish. I just wondered if at this stage in your practices that are you able to prescribe certain kinds of foods, certain kinds of like supplements and that type of thing?
In addition to the
Yes.
medication? Oh, okay.
To build kind of a strength around the situation.
So for me, when you walk in my office, whether it's the medical side or the med spa side, everybody is offered the diet I had put together. So it's broken down into food groups. Everything on it is a low glycemic index, so less than 54. And everything on there is going to help to decrease inflammation in the body. So it's not only, I'm not only following how much sugar is in there, you know, what type of food is going to actually trigger your hunger center, but also decreasing the inflammation in your body is going to help your body to work more efficiently, and you're going to be able to get to the weight that is healthy for you, and give you more energy. So in addition to just going off of that, in addition to the diet that I offer, we also have an infrared sauna, which has been shown in research to mimic exercising. So your heart is beating faster, you're sweating, you're detoxing, and it does something to the brain to actually want you to start working out, especially for someone who was generally working out on a regular basis and kind of fell off the wagon. And I know it's happened to me, you know, in certain times in my life. I love working out, but there's like when I had to have my rotator cuff surgery done or I had back surgery done years ago, it's really hard to get back into it. And the first couple of times you start working out, every single bone in your body hurts. And so for people like that coming to the office and going in the infrared sauna, and which helps them to lose even more weight, you can actually lose up to 600 calories in 60 minutes in these infrared saunas because of how it gets down to the cellular level, those far rays. So in addition to the diet, I also include the infrared sauna. And then we have IV treatments as well. We have B12, we have something called the skinny shot that's a combination of different vitamin Bs that work synergistically together to allow your fat cells to be used as energy. So you see results quicker because we're getting rid of that fat pad over your abdominal area. So that's what we do in my practice.
And in my practice, since the GLP-1 slowed down the absorption in the gut movement, we have this new multivitamins because especially in GLP-1 with decreased absorption, they can be deficient in B12s and some other multivitamins. So the nanotechnology particle-based multivitamin, instead of taking the bulky, chalky vitamins, which are difficult to swallow, which can cause nausea, we have this nanotechnology-based. It's very simple, just a small capful of liquid provides all your vitamins, supplements in one capful. Just swish and swallow. All the absorption happens at your mouth surface. Nothing, no need to drink lots of water with it. So it enhances your absorption. It avoids any drug interaction in the stomach. It has, I always recommend my patients to get both vitamins and supplements. And hydration is also very important. Hydration means not just water with electrolytes. So we always want, the most common side effect, and the adverse event happen because of nausea and diarrhea. So when that happens, it's very important they hydrate with electrolytes. So we also add a complement of electrolytes and supplement in a liquid form. Thank you for the question. Thanks.
Anyone else?
I think, did you, she had a quick one.
Did you have a quick question?
Yeah.
It was a quick question. It's just pediatrics and just what is the conversation now for the ages going down to teens and preteens?
It
as
is
far as
approved for 12 and above. I
And
have
is
done for teens.
Approved but recommended? I mean, are you guys using them and with good results?
Yes,
And
if any young adult, I have a teenager who takes it, she's 17-year-old, and she has PCOS and metabolic syndrome, and she needs it. So it is, yeah, she's doing great. Thank you.
Thank you so much for joining us.
Thank
Thank you
all.
so much,
Thank
audience,
you.
for the engagement.